Start this time with hematology. Hematology's, we've been talking a little bit about hemoglobin.
Oh, yeah.
But hematology would be a way to do an assessment of the blood, right? And so within hematology, there's a CBC. What does the CBC tell us? Complete blood count. So we want to know mostly what the red blood cells and white blood cells. Yeah. So which one do you want to talk about first, red or white?
Red.
Red.
Red cells? Red's the most interesting, right? Because it carries oxygen. And
We love oxygen.
And oxygens are, that's what makes respiratory care practitioners special, is how we carry oxygen. So we do it on the red blood cell. The red blood cell is, like we've said, a physical weight. If we spin out a deciliter of blood, the red cells sink to the bottom, and it's in a deciliter of blood, hemoglobin weighs 15 grams. Okay? So most of us would have an average of about 15 grams of hemoglobin in a deciliter of blood. So hemoglobin is normally around 15. Those are produced by erythrocytes or normoblasts. Red blood cells are produced in the bone marrow. Types of studies we can do in hematology are SED rates. Have you heard of that? What's a SED rate?
SED rate?
SED,
How
S-E-D.
fast it's settled?
Yeah, sedimentation, how fast it sediments down through the plasma. So a SED rate is usually, we just make sense of it in terms of an increased SED rate or a decreased SED rate. If it takes longer, that means that there's more plasma proteins in the blood, and it takes longer to settle. So usually if you have blood in a tube, I've seen them in labs, they'll tape it to the wall, and they'll measure how much time it takes to settle out the red blood cells to the bottom. The rate of sedimentation is relative to the number of plasma proteins in the blood. So a higher SED rate means it took longer to sediment out. And yeah, usually it means inflammation or more plasma proteins or an inflammatory process. So an increased SED rate means that there's an inflammation process. Now, they're getting more and more into specific numbers like the A1C that they're measuring for inflammation and CRP, creatinine reactive protein, CRP, which is more towards heart disease or heart inflammation. But what's happening in the blood vessels with these inflammatory cells or inflammatory mediators is that they think that it's causing endothelial damage. And so a lot of pathologies, for instance, coronary artery disease, is caused by inflammatory markers like CRP and A1C. A1C is for diabetes, right? And CRP is specifically for heart. But in inflammation, it affects the endothelial cells. The endothelial cells become thickened and hardened, and next thing you know, you've got inflammation and cytokine reactions to the endothelial vessel. The endothelial vessel causes cholesterol to build up, high levels of fat, and coronary artery disease is the result after years and years and years and years of abuse. Clinical symptoms don't occur in coronary artery disease until 75% of the vessels are occluded. So in the U.S., anybody know how many heart attacks a year? Somewhere around 600,000 attacks. In approximately 25% of those, so around 125,000 heart attacks, their first clinical symptom is death.
What?
Yeah.
There's like, it's just
125,000 of the 600,000 heart attacks in the U.S., the first clinical symptom is death. So they don't survive. They have a catastrophic event, and they don't have heart pain, chest pain, arm pain, jaw pain, back pain. They don't have any of that. Their first symptom is they drop over dead. So we call that sudden death. So sudden death is often in a quarter of the heart attacks in the U.S. the first clinical symptom. And it speaks to this endothelial inflammation. So I'm not saying that you can predict heart attacks by a SED rate or by CRP. It's just that the incidence of inflammation is extensive in hematology studies.
And it's SED rate or SED?
SED, S-E-D, sedimentation, SED rate. So an increased SED rate just generally means an inflammation reaction, endothelial damage, and it's due to plasma proteins. Okay. So granted that's a pretty big stretch from a SED rate to talking about arterial sclerosis, but that's the pathology. That's the pathology that we see and that you'll interact with. Is that these patients sometimes have catastrophic events due to chronic long-term inflammation. Go ahead, Armando.
I was going to ask, I know that autoimmune diseases usually have high SED rates, but
Yeah.
why is that?
Because of plasma proteins and markers in plasma that causes, it takes longer to sedimentate out.
Okay.
So it's just a broad overall generalization to suggest that inflammation causes an increased SED rate. Okay, so red blood cells, we know normal RBCs are in a deciliter of blood is 15 grams. That hemoglobin carries 2 alpha and 2 beta chains. We'll talk about that in A&P next week. Those 2 alpha and beta chains all have a molecule of iron. Iron's oxidized to a +2 state, which is ferrous iron, and that when it oxidizes to a +3 state, that's called ferric iron, and it makes it inefficient in carrying oxygen. So there are certain things, herbal supplements and cetacane, that seem to create methemoglobinemia. Okay? So a methemoglobinemia is anytime iron is oxidized to a +3 state and we have more than about 3 grams percent oxidized to a +3. Go ahead.
And did you say that inflammation causes that to happen?
Not the methemoglobinemia. Herbal supplements and cetacane can cause methemoglobinemia, which is where we oxidize iron from a +2 to a +3 state, a ferrous to a ferric iron. And so we're always infinitely concerned about oxygen transport and how we carry it on the hemoglobin and how we deliver it in the plasma. The combination of those two things is called oxygen content. We'll do much more next week on oxygen content, how we transport oxygen in the plasma and how we combine it to hemoglobin. The majority of oxygen we combine to hemoglobin. We carry a very tiny amount dissolved in plasma. It's almost inconsequential, but we do account for it in oxygen content. But like I said, we'll do that next week. Okay, white blood cells. So I'm not going to say much about red blood cells other than what's an increased number of red blood cells? Anybody? Polycythemia. Yeah, so an increased number of red blood cells is called polycythemia. A decreased number of red blood cells is anemia. Very good, Armando. Anemia. So if we take our normal of 14 to 16, a high level of red blood cell polycythemia, low level of red blood cell anemia. And we sometimes make sense of how well we carry oxygen by hemoglobin. White blood cell count is a representative of the immune system. So all white blood cells, most white blood cells are produced in the bone marrow. Another name for white cells is called leukocytes. So a leukocytosis would mean an increased number of white cells. A leukopenia is a decreased number of white cells. And then we can also differentiate, we did this in chapter 5 of A&P, we can differentiate the polymorphonuclear granulocytes, right? Those are neutrophils. Neutrophils are the initial response to stress. So in polymorphonuclear leukocytosis or polymorphonuclear granulocytes, that just means that we've increased the number of neutrophils is the first response to stress. Inflammation, steroid use can sometimes raise neutrophils. In neutrophils, we sometimes count the number of banded cells versus segmented cells. So what that means is in neutrophilic leukocytosis is that there are cells that look like this, and then there are cells that look like this. Okay, so these are white blood cells, and in particular neutrophils. And the neutrophils, these are called bands, and these are called segs. So what does that mean about the different kinds of cells that we see in neutrophils? Banded cells, I can tell you, are immature cells. If they've been around for a while, they begin to become segmented. So each one of these segments become, there's a nucleus in each one of these. So, but band cells are immature, and segmented cells are mature. Well, why do we care if white cells are mature or immature?
Well, if they're immature, it means your body's starting to produce more right then.
Yes, very good. If you have a predominance of banded cells, it means that the infection is acute.
Mm-hmm.
So if you have 50% or 60% banded cells, it means that the patient was just exposed to the inflammatory process. Now they're starting to build up an immune response, and the majority of cells are banded. So they're immature cells because it's an initial response to an acute infection. Okay? So we can make a broad determination about the kind of inflammatory condition based upon the kinds of cells there are. So in neutrophils, if there are a predominance of banded cells, it means that the infection is an acute infection, an acute onset. If the cells are more segmented, it means the infection's been around for a while, and usually we'd see like 20% banded and 70% segmented. What does that mean? It's a chronic infection. Okay? So in COPD, they sometimes have high segmented cells because the infection's been around for a long time. They've had a while to build up their immune response, and so the majority of cells, white blood cells, particularly neutrophils, are segmented. It means that it's a chronic infection. So it allows us to say something about the acute or chronic nature of inflammation. Okay, if we know something about the type of cells that we're seeing. So bands or segs. Neutrophilic, so that's neutrophilic leukocytosis means a proliferation of white blood cells that are neutrophils, right? Neutrophilic leukopenia means that it's an overwhelming infection. So if there are more disease-producing cells that overwhelms the mechanism of defense for white blood cells, neutrophilic leukopenia means that the infection has overrun the body's ability to fight it. So cells are produced expended faster than they're produced. Neutrophilic leukopenia. Another type of white blood cell is the eosinophils. Where do we see eosinophils?
Asthma.
Yes, we sure do. It's allergic responses, absolutely. So if a patient has eosinophilic leukocytosis, it means that you start looking for asthma as a possible cause to why they have an increased number of eosinophils. Yeah.
Is it the eosinophils that creates the harder beating crystals in your lungs?
A good question. That would be a great research. You're already in the advanced class. I usually have to do research abstracts.
Good job.
But that would be a good question to try to research. I'd like to find the answer to that. I don't know the answer.
No, because I read that like in the asthma section.
Oh, really?
That it changes to like a crystal.
I'm gonna have to find out. So was it in the text?
Yeah.
I'll find the answer to that and let you know.
Cool.
So eosinophilic leukocytosis we would usually see in an asthma type reaction. We know that the eosinophils are caused from allergic type reactions. So in So if we have an increased number of eosinophils, we look for allergic responses. If it's chronic infection, we have more neutrophils, we just look for overwhelming inflammation, not necessarily an asthmatic type reaction. What about basophils? Where do we see basophils?
Is that reaction that happens? Oh, no,
Not specifically. It's still an inflammatory process.
It's a big,
Myeloproliferatory.
Yeah.
is it parasitic?
Sometimes with parasites. What else? What else did the text mention?
Myeloproliferative disorders.
Okay, with
Or-
muscle
and
muscle
also-
disorders,
Allergic to stress
Okay.
response.
stress responses. Now you can get neutrophilic leukocytosis from stress response too. So it's not always very specific, but we can generally say that just an overwhelming number. Although I don't often distinguish basophilic leukocytosis in overwhelming infections. It's usually neutrophils or eosinophils, and we can make the distinction between allergic reactions versus inflammation, just generalized inflammation.
Does it produce like histamines too?
They can, and that's the cascading effects of inflammation to begin with, but it's usually from mediators inside the endothelial wall. We see slow-acting factor of anaphylaxis. We see other things that histamine production, which is a response from an allergic type reaction.
Okay.
So neutrophils, eosinophils, basophils are all white blood cells that we can see increases of, which would be leukocytosis, decreases of, which would be neutropenia or leukopenia if it's an overwhelming infection. Another type of white blood cell lymphocytes are usually seen in viral infections. So we can broadly suggest that if there are viruses. Now, I've noticed there are all kinds of viruses lately, especially for kids. Kids are getting all kinds of viruses. In fact, in California, have you noticed they've reported several cases of muscle weakness from the neck down? It's a viral infection, and it's causing, I wish I could remember the name. I'll have to look it up, but it's causing broad spectrum muscle paralysis from the neck down in previously healthy infants less than about 5 or 6 years of age.
Does it come back? I mean, is it like a normal virus that it just like can go away?
It does, but it's causing long-term paralysis in some patients.
What?
Yeah, wish I remembered what the name was, but it's a viral infection. So these patients show an increased number of lymphocytes in their white blood cell panels. So lymphocytes are white blood cells that are not produced in the bone marrow. The others are. So lymphocytosis would mean a proliferation or an increased number of lymphocytes. Viral infections. Lymphopenia we sometimes see in trauma or acute infections. So all the lymphocytes are reduced as a measurement to overwhelming infection.
Where were the lymphocytes created, did you know?
They're the only one not produced in the bone marrow.
Okay. Is there a specific location where they're
Not
created?
specifically. In the lymph.
Yeah, lymph nodes.
Monocytosis. So these are not polymorphonuclear leukocytes. These are monocytes, so they have single nuclei. Monocytes, we look for evidence of leukemia. So if we see a predominance of monocytes, it's usually chronic infection, tuberculosis, fungal diseases, and typhoid. So in third world countries, typhoid is common. We usually see monocytosis because of a chronic inflammatory process. Okay, so I think we're starting to see more, or at least more prevalence of disease pathologies that are the result of fungal lung diseases. Those are specifically histoplasmosis, blastomycosis, coccidioidomycosis, and aspergillosis. But if you've noticed, there are some commercials on television now that suggest that if you visit a certain region where fungal lung diseases are common, not to take like Humira. Some of the some of the medications that are out there give us specific advice about reducing, because what these medications do is they reduce the immune response. So if you reduce the immune response and you're exposed to areas where there are fungal lung infections, now we sometimes have molds here, but histoplasmosis is common in the Ohio River Valley, so we don't worry too much about that one. Blastomycosis is in the southwest United States. Coccidioidomycosis is in the San Joaquin Valley in New Mexico, Arizona, and the dry deserts. If you've heard of San Joaquin Valley fever, that's coccidioidomycosis. So there are fungal lung diseases that are becoming more apparent, or at least I see them more often because of our proximity to certain kinds of environments that preclude us, that make us predisposed to certain kinds of infections. And now we're giving medications that reduce the immune response to inflammation. So we have to be on alert for patients that are taking medications that make us predisposed to certain kinds of infections. And fungal lung infections are becoming more common. So we need to know the difference between leukopenia, which is a decreased white blood cell count, and a leukemia, which are proliferation of white blood cell counts. Okay. Also in the blood, we sometimes do platelet counts. Platelet counts help us with coagulability, clotting factors, you bet. So do you know the difference between, let's see, a coagulation study, so bleeding time, usually a bleeding time measures clot formation, it should be within 6 minutes. So normally you should be able to form a clot within 6 minutes. And within that clotting time, we do 2 tests. One's a PT, a prothrombin time. A PT, you should see clotting within 12 to 15 seconds. And a PTT, what's that? Partial thromboplastin time. Okay, so partial thromboplastin time. But the way I remember that is that the PT, when we see him on a hematology test, we do a PT, a thromboplastin time, and a PTT. So the 2 T's form an H. So I know that heparin influences a PTT. Is that a good way to remember that?
Ah.
So if you take heparin, what you're doing is you're interrupting the prothrombin time in the formation of a clot. If your PT is influenced, we take a drug called warfarin to help to reduce the clotting factor. Okay? Or Coumadin is another name for that. Warfarin, or Coumadin, Coumadin or warfarin. So Coumadin or warfarin interrupts the PT. A normal PT is 12 to 15 seconds. Partial thromboplastin time is plasma forming a fibrin clot within 32 to 51 seconds. So 30 to 50. So if a patient's on heparin, that would increase the PTT. Why would you care what the clotting time was in a hospital setting?
For surgery.
Yeah, exactly. If you're going to surgery and you're going to cut them from here to here, you want to know how fast the blood's going to clot, or if it's going to at all, right? If you have increased PT or increased PTT, that's going to influence the time it takes to clot, and it could prevent them from healing properly, or they could lose an excessive amount of blood too. So they'll do a PT and a PTT to see what the clotting factors are, so they can start, they can recover.
Does fibrinogen have anything to do with that too?
Yes, it does. That's in the PTT, the fibrinogen, partial thromboplastin.
Okay.
Because what the thromboplastin is doing is it's forming a fibrin clot. Okay, so the PTT. Heparin's hard though to monitor. You have to go to get a blood test every 7 to 10 days, It has to be within a certain range. It can't be too high, it can't be too low. So they'll alter the heparin higher or lower. It's really hard to manage outside the hospital. Whereas Coumadin or warfarin has a little larger range and it's a little easier to monitor, although it's still hard to keep within such a narrow range, 12 to 15 seconds. Okay. Another medication that alters PTT is Lovenox. Have you seen? We've seen them use that in the hospital quite a bit lately. So patients that are susceptible to PEs, they'll give them a Lovenox injection in the abdomen just to keep their PTT a little bit longer, to prevent fibrin clots in deep veins in their legs. So if you're at risk for PE, then they might give Lovenox. They might, in the hospital, they might give them heparin, and outside the hospital they'd give them Coumadin. Okay. Last piece in patient assessment is urinalysis. So what does the urinalysis do as far as help us make decisions about the care of our patients? Kidney function, that renal function. So basically, it's a screening for kidney function. We look and pay attention to the appearance. You know, if it's yellow, if it's light yellow, if it's dark yellow. Specific gravity is an important piece. What would increase specific gravity?
Yeah.
Go ahead.
Dehydration.
Yeah, it makes the urine more concentrate, and the more concentrated it is, the higher the specific gravity is. Or if it's dilute, if you've been drinking lots of water, that'll make it relatively dilute. So specific gravity is an important piece to how dilute or concentrated the fluid is. They'll look at pH, they'll look at the presence or absence of proteins, whether or not you're spilling sugar into the urine is a function of diabetes. So how you're monitoring insulin in the bloodstream. Presence or absence of ketones. If there are ketones, it could mean ketoacidosis. So we would measure that along with a pH to see if the patient has diabetic ketoacidosis. Whether they're BUN, certainly, what the urea nitrogen is. Blood in the urine, always not a good thing. We start looking for obstructions or calyxes or stones, renal stones that can cause blood in the urine. Presence or absence of bilirubin and or nitrates. So even though it may seem like a distant association, and it is, you know, we're concerned with the volume and the amount. Because some of the treatments that we give to improve oxygen involves giving pressure, and the pressure reduces the circulation through the kidneys. If we reduce the blood pressure less than 60 millimeters of mercury, then we're reducing the blood flow. If the blood flow is reduced, then we don't create urine. And so the amount is important, the color is important, the specific gravity is important, whether or not there's bilirubin or glucose or ketones in the urine. So it helps us to make associations with cardiopulmonary disease. It may not seem like it's an important connection, but all the mechanical ventilators that use pressure to push air into and out of a patient's lungs will influence the volume that gets to the lungs and how much urine we produce. So I would often ask what the urine output was in the last, if I was coming on to a intensive care shift in the ICU, one of my first questions is how much urine did they produce in the last 6 hours? Because it's an indicator of how good the perfusion and blood flow was to the kidneys. And the nurse would always look at me kind of funny because I was the respiratory therapist. I should be concerned with the lungs and the heart, not the kidneys. But it always, if they were on a ventilator, it always included an assessment of the urine and how much volume there was. So don't forget to make that association. It's an important piece in patient assessment. Taking into account what's going on with the whole body, not just the lungs or not just the heart, but the heart, the lungs, and the kidneys are all interconnected. And how we assess those three systems comes back to how well we make clinical decisions about the care of our patients. So I'll leave you with that for today. We'll do a review next week on patient assessment. It'll be the first 2 modules on patient assessment of the signs and symptoms, the history and physical, and the last section